Hello, welcome, and thanks for joining us to help choose home when care is needed. A podcast all about the benefits, value, and safety of receiving care and services in the one place that feels most comfortable, wherever it is that the person needing care calls home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Before we meet today's guest, a brief thank you to our sponsors and partners, the National Association for Home Care and Hospice, Access, and clerked. Today's episode is number 2 of Season 4. Our guest today is Edo Banach, President and CEO of the National Association for Hospice and Palliative Care. Please help me want you and welcome Edo Banach to Help Choose Home. Edo, thank you so much for joining us today. It's really our pleasure to have you on the podcast.
Pleasure's all mine. Thanks for having me.
Right. And I'd like to start really by talking about hospice. And it seems to me that right now in the home care and hospice space that there could not be a better time for support from a policy standpoint. Are you feeling that way as well?
Yeah, absolutely. I think hospice is a benefit that really came to be in the late 60s and early 70s as a grassroots movement, became a benefit, and really has been chugging along for 40 years, much like PACE in that sense. It's been chugging along, waiting for the moment to be right and waiting to be recognized by the rest of the healthcare system. That's a double-edged sword, right? Because the rest of the healthcare system, the medical industrial complex, the insurers and the hospitals are now and the administration and Congress are now kind of looking at, okay, so who does what in the home? How can we provide more of that home-based interdisciplinary care? And so it's great that we're getting all this attention. We also have to maintain quality and integrity, and all those things are important as we ramp up a benefit to provide more care to more people earlier. And that's a challenge we look forward to.
And tell me, is there a strategy for getting care to start earlier for when someone needs hospice?
No, we figured we'd just wing it. No, I think that, honestly,
you've been doing it for the last 40 years.
Well, I'll tell you. So for the last 40 years, what's allowed hospice to prosper in a sense is the same thing that holds it back. What's allowed hospice to prosper is it's a separate benefit. You have to have a prognosis of less than 6 months to live, and you have to give up curative care in order to get it. So, what that does is it gives the benefit a little bit of time to mature over in its own space. But that's actually not what we need now. What we need now is for that whole continuum that really begins with people declining, having to seek care to begin with. Sometimes get care in the hospital, sometimes get care in the nursing home, sometimes get care from home health, and sometimes get care from hospice. Most people aren't satisfied by that journey, right? You have to get broken in order for the system to fix you. The system is too medicalized and it's too institutional. And so the last thing we want to do right now as hospice is say, we'll be over here in the corner, leave us alone until you've got a couple months or a couple days to live. Then at that point, it's our time to shine. The strategy is actually to say that stuff, interdisciplinary, sometimes non-medical, non-institutional, usually, care is actually something that a lot of people need when they're chronically ill, when they're seriously ill, and when they're at the end of life. So short-term, the strategy is to work really hard, and we've been doing that with a lot of receptivity from Congress and the administration on a community-based palliative care benefit that you can wrap your arms around. And what I mean is that there are quality metrics, there are standards that exist for a word that a lot of people have been using for a long time without definition. And then the second thing is to evolve the hospice benefit itself. Why do you have to give up curative care in order to get palliative care? Why is it only available for 6 months? These are arbitrary decisions that were made at a time that we had a cancer benefit and the government wasn't sure about whether the benefit was going to cost more and whether quality was going to increase. Well, asked and answered, right? It actually saves money. It actually improves overall well-being and quality. We're reducing access to it for really because somebody at OMB in 1982 thought so. All right. So I think that's really, short-term strategy, community-based palliative care, medium-term, begin to sort of create that new continuum. And it's going to require, obviously, a lot of work with home health and nursing homes and hospitals, really everybody. We've got to work together in order to create a better continuum for people.
Okay, now you and I both know this industry very well, but our consumer audience may not. So I'm going to back you up a little bit and ask you to define palliative care and also to better define what you mean by the hospice benefit that is currently in place.
Absolutely. So I began my career as an advocate at the Medicare Rights Center. And really, it's near and dear to my heart, and it should be to all of ours, to talk about the benefits from a consumer perspective on the delivery side of things. When I talk about palliative care, I mean community-based, interdisciplinary, meaning a team of professionals, a team of different people, including the patient and the family, coming up with a plan of care that isn't limited by what's medically necessary, because we're not talking about medical services often. We're talking about things that are going to make you comfortable and supported. A lot more likely to exist in Medicaid, long-term services and supports, than in Medicare. So this is really the beginning of Medicare offering more of the things that people think that Medicare provides. You know, when loved ones say that they're going into Medicare, most people think that Medicare is a benefit that provides long-term care, supports and services. Actually, it doesn't provide any of that stuff. It provides much more than medical stuff. This is the attempt within the Medicare system to provide interdisciplinary, community-based, often non-medical service before the end of life, often way before the end of life. And I think the best way to talk about it is through the eyes of three people, and two of them happen to be related to me. One is Great Aunt Ruby. She's got COPD, chronic obstructive pulmonary disease. She is near the end of her life, but not at it. She has trouble walking. She has trouble doing a lot of things. And if you think about the Medicare system right now, if she gets a kink in her line or if she has difficulty emotionally, what are her options? Well, her options really are to go to the urgent care clinic down the street or go to the hospital. There's no home care for Great Aunt Ruby because she didn't have a stay in an inpatient facility and she's not coming out. There's no palliative care. Really, the thing that we're trying to do for Great Aunt Ruby is, can you pick up the phone and call someone? Maybe that'll calm you down. If it doesn't, maybe someone can come out and make a visit. If they need to fix your device, they can fix your device. If you need therapy or counseling, they can provide therapy or counseling. And if you need medical care, they can provide medical care. All meant not to cure your COPD, because there's no cure for COPD, but to make you more comfortable in the home so you don't have to decline and go on that chain. The other example is my other great aunt, who unfortunately passed away, 90 years old, living in a fifth floor walk-up in New York, and perfectly healthy, although 90, and living in a fifth floor walk-up. What she needed was help in her home so that the inevitable didn't happen, right? The inevitable being she fell down the stairs, ended up in the hospital, and from there to the nursing home, and from there to hospice. So we're not often talking all the time about fixing you after you've been broken. We're also talking about preventing declines. Same thing for an Alzheimer's case. And this is my third example. People with Alzheimer's can't be cured. There's no cure for Alzheimer's, but they need support in the home. And sometimes right now, people are discharged from hospice because they're not dying soon enough. And what happens is they get dumped into the rest of the healthcare system. What a tragedy. This would allow you to create a dementia-specific benefit that would keep people safe in the home until a time when they required a higher level of care.
And do you see receptiveness? You have a background in CMS. Do you see receptiveness now with this current administration and with CMS to take a broader look at benefits for people who frailty to the grave?
Totally. I was there during the Obama administration. These are conversations that began then. And it often takes a long time for something to go from conversation to benefit. But I can tell you that some of the same people that I was talking to about these issues are there now. And so that gives me some confidence that there's certainly a receptivity to it, if not, more than that. The other thing that we've seen, and this is the first that we're going to talk about it, but obviously COVID. Now, COVID one could think is a virus that has nothing to do with any of the stuff that I've been talking about. But I would push back. I would say, well, wait a minute. We have a serious illness that killed 500,000 Americans. Almost none of them received hospice, but they certainly could have used some help in the home. That's kind of what we're talking about here. So if anything, our argument's gotten stronger. We also have some champions on the Hill. And usually the way that we create champions for these issues is in an unfortunate way because they've had an experience with the status quo, with their parents, with their loved ones, and they want to do better. And it's bipartisan. And so I have hope. I really do.
Oh, good. One of the things I say frequently when I talk to people who ask me questions is to say this: our healthcare delivery system is very complicated. Yeah. So if you want home care, it's really complicated. Unless you have a lot of money, then you can get whatever you want. But so how do you see this healthcare delivery system? Because the scenario you have just painted for me does not have us in buckets for reimbursement, which is what, in my opinion, we have now.
Yeah. I mean, what we have now is you go from bucket to bucket, depending on how the provider can bill for you. And you're not treated as a person. You're treated as a DRG, or you're treated as a vessel for receiving reimbursement. So I think the direction that we've already been moving in, for better or worse, is that either providers or insurers are given a lump of money. It's Medicare Advantage in insurance land. It's ACOs or direct contracting or risk-based payment. There are a lot of words for what we mean. But think about one entity given a bunch of money and given autonomy or freedom to provide you anything that's necessary that you need. And it's a negotiation between the payer, the provider, and the consumer to make sure that people are getting what they need. The philosophy is that all three are aligned around giving people what they need. And if they don't, that people will go to someone who does. Is that going to happen? Not automatically, right? The market doesn't work that way automatically. It's going to need a lot of advocacy to make sure that people actually get the care that they need. And that I think is going to have to be part of the design of any program that we build up.
So right now, if I wanted to drop a consumer into that model is in theory only and not in practice, correct?
Yes and no. In practice, there are models like this in a couple of places. One is PACE, which I talked about, defined population, defined places, not everything, not everywhere, but it exists. The other is that there are a few managed care companies that actually do provide community-based palliative care, and a few ACOs that do the same thing. The problem with this is that there's no bottom, there's no standardization. So Tony's Palliative Care, Humana and Sutter can all provide something called community-based palliative care or serious illness care or transitional care, but they kind of make it up. And what I'm advocating for are quality standards and metrics that set a floor. You can certainly innovate. You can provide great care above that, but you can't dip below it and use those words.
So how do we get there from where we are today?
First thing is we have to have buy-in from the top and we have to have buy-in from the bottom. I talked about the top and the work that we're doing with CMS in Congress. We have to demand it. I had a conversation as part of our conference, the leadership conference that we had a couple of weeks ago, with Leon Panetta. And Panetta is known for being a defense secretary and head of the CIA and chief of staff. But before all that, he was a member of Congress who was one of the people that was instrumental in getting hospice to begin with. And what he talked about is a meeting that he had with a very, fierce advocate in California who was talking about this problem that he had with his loved one. And at the time, Panetta was going through the same thing with his mother. So, you need both. This is the recipe. You need a grassroots army demanding change, and you need receptivity to what that grassroots army is asking for. And people forget the hospice benefit was a theory in the late 60s in England. It became a benefit. 10 years later, and only 10 years later, it became a full benefit in a demo in this country, 1978. And 3 years later, it was an actual benefit. So, the people who came before me, a couple generations before me, were able to sort of marshal both of those things. The top grassroots, and I think that that's going to be required. We all have to be fed up with access to care that we have, and quite honestly, fed up that we make people jump through the hoops we make them jump through. And I see us all as advocates for demanding change. It's going to require a little bit of discomfort because we're letting go of something that we hold near and dear, but we've got to do it for patients and families.
In my 42 years in the care at home industry, what I have recognized is that people do not seek information about care until they need it or a loved one needs it.
Right.
And prior to that, they don't seem to have any interest in it. So how do we generate that grassroots interest when people don't see the need until they actually experience a need themselves or have a loved one with a need?
Yeah, this is one of the reasons why we, have to move upstream. And it's partially because we're never going to cause people to want to talk about death in this country. Culturally, we have an aversion to it. But I think that where we have more of a likelihood of success is in getting people to talk about, and I think COVID actually helps, what type of care do you want when the time comes? Here's what's going to be the automatic. Do nothing, and this is the kind of care that you get. Here is something that, and I think it begins with the advanced care planning conversation, which is often poo-pooed, but have a conversation about what your wishes are. Have a conversation about who your healthcare proxy is going to be. Then let's talk about the reality. What type of healthcare can you actually get? I think all of that's going to require, a recipe of, getting some trusted folks to sort of deliver that message. And I'm not saying folks who are on their last legs. Folks who are right there in the middle, struggling like everybody else is with quarantine and senior care and children and everything else. And I think that that's going to be a big part of our PR push going forward to kind of demand this change.
Do you have any off the top of your head messages that are hospice-specific messages that you say when people ask you what's the benefit or how does hospice help?
Yeah, all of the parts of the healthcare system where you kind of wish that the healthcare system would listen to you and build a team around what you need. That's what hospice is. Hospice is a team of people working with you to get the kind of healthcare and care generally that you need. That's the simplest way that I can describe it, because it's a different journey for everyone. Some people want a chaplain. Some people want a music therapist. Some people want, nothing at all except for medication. It's important that the benefit be tailored to the person and not have the person say, sit there, take a number, we'll get to you when we're ready, because that's the rest of the healthcare system.
But the hospice system right now is that interdisciplinary system that does have a patient focus at its center and its heart, correct?
That's correct. That's correct. That's what we want to make the rest of the healthcare system look a little more like. And the bridge to that is what I describe as community-based palliative care.
Right. That's a very bold and aggressive goal. So congratulations.
Well, and it's just a goal. But if you don't have bold and aggressive goals, then, the good thing about bold and aggressive goals is when you fail, as you often do, you're still pretty bold and aggressive. You just haven't gotten as far as you wanted to. So that's my strategy, is to be bold and aggressive and know that even if we fall a little bit short, we'll still be way beyond where we are now.
I believe we are 9 years away from the baby boomers, most of the baby boomers hitting that 85 plus age. And at that point in time, if we think we have scarce resources now, we are really going to have scarce resources.
Right.
In this 9-year time period, are we doing enough to implement your vision of what the healthcare delivery system should look like?
Well, I think I'm doing enough, but I think it's going to take much more than Edo Banach or an HPCO doing this. I think it's going to take a couple of other things. First of all, the entire care at home segment has to have a grown-up conversation about the way we work together going forward. Second of all, I think employers need to be a big part of this. One of the reasons why Amazon tried but ultimately failed to build a model with Atul Gawande was because they were really concerned about the time and energy being spent by their employees on some of these issues, because the healthcare system is so broken. And then I think we're all going to have to work together to marshal that public support for change. Are we going to do enough? We don't have a choice. And I don't think it's just for this. The other thing that we haven't talked about, and is a sense bigger than bigger than what I'm proposing, is true long-term care reform. We have no long-term care system in this country. So palliative care is a benefit that I'm describing that treats people who are seriously ill. It would be absolutely essential that we have a benefit that comes even before that treats people who are just chronically ill. And that's a much bigger conversation and a lot more money. But I think it's much more expensive to do nothing. Because if we do nothing and people end up requiring, emergency or institutional care, it's more expensive. So I think we need a fundamental reform of our Medicare, Medicaid, and long-term care system. So by comparison, what I'm proposing is modest, right? So I think we can do it.
Good. That's exciting. And you may have just answered this question, but my last question to you is, was there anything that you wanted to say that we did not touch on today?
I feel like this is a job interview. I'm a little nervous. I want to make sure that I say all the things. I think that what I want to say is that all of this has to come from the head and the heart. I think that often what divides us in healthcare and in care generally is you have some people who are motivated by money and you have some people who are motivated by heart, and they both hate each other. And in reality, people are mostly a combination of both. You have a little bit of heart and you have a little bit of head, and you got to find common ground on how to, move forward a system that allows us to care for more people earlier. And I think that so long as we keep that in mind and all work collaboratively, I think we can move mountains.
Well, that is a wonderful way to end. And I want to say thank you so very, very much for joining me today. And I think your words will be appreciated by our consumer audience. And I wish you the very best in your quest to affect this healthcare delivery system.
Thanks so much. And for those of you who are inspired, nhpco.org, and join us.
Thank you. Thank you so much for listening today. And a special thank you to our sponsors and partners, the National Association for Home Care and Hospice, Access, and clerked. If you have not done so already, please subscribe to our podcast and take the time to leave a review on Apple Podcast. We're now also on Spotify and most other places where you find podcasts. Like and follow us on social media and join us. Want you to spread the word and help choose home when care is needed.